Okay, so good day and welcome to our presentation entitled Toward Quality Mental Health Care, Dismantling Structural Stigma. I am Kamlesh Tello and I am joining from the Mental Health Commission of Canada, and I am pleased to be your host. I would like to begin by acknowledging that the head office of the Mental Health Commission of Canada is located on the unceded traditional territory of the Algonquin Anishinaabe Nation in what is now called Ottawa, Ontario. As a national organization, we also acknowledge that we work on the traditional lands of many different nations. Today, a path to truth and reconciliation begins with recognizing both the stewardship and the sacrifices of the original peoples. We are committed to recognizing the errors of the past, acknowledging the challenges of the present, and contributing to a new and respectful relationship with the First Peoples. Through working closely with our panelists in preparation for this webinar, our team is also learning how we can learn the way to dismantling stigma in how we relate and work together. And I am thankful for the safe environment that the team has created so that we may learn and support one another in meaningful ways while being kind and respectful. We invite you to acknowledge the territory that you are joining us from today in the chat box. I am joining from the Algonquin Anishinaabe Nation, and I'm also pleased to share that we have approximately 500 registrants, including a few international folks for this webinar, and we're so excited to see how much interest there is in the topic. Next slide, please. Before we begin, a couple of housekeeping notes. We are pleased to be offering this webinar in both official languages. Today's webinar will be presented in English with simultaneous French interpretation. To activate simultaneous interpretation, click on the interpretation button at the bottom right of your screen and select your preferred language. We encourage you to enable interpretation to ensure that you can participate in the webinar in your language of choice. The webinar slides are also available in both English and French. If you would like to follow along the slides in French, please select View Options at the top of your screen and select French option under the heading Shared Screens. Next slide, please. There will be a Q&A period at the end of the presentation. Please feel free to type in your questions for the presenters in the Q&A box. We also encourage you to share your comments in the chat box. If you experience any technical difficulties at any point, please let us know. And also the session will be recorded, and by participating in today's conversation, we assume your consent. A recording of the conversation will be posted on the MHCC website in early 2024. The subject matter being discussed throughout the session may deal with sensitive, uncomfortable, and potentially triggering themes. Please take care of your well-being, and if you find that you need some support, reach out to the resources listed on the screens on the next slide. We welcome you to take a picture of this slide for reference, and we'll also add the information about these resources in the chat box. And now it's my pleasure to introduce one of our panelists, Bill Hill Nlotni Gungatste, co-CEO of Nojimo Health, Canada's first all-Indigenous virtual mental health clinic. Bill has graciously offered to open our webinar in a good way. Prior to starting the session, we have passed the tobacco to him, and I will now turn it over to Bill for the opening. Thank you, Bill. If you want to just unmute yourself, please, Bill.
Good idea there to do that with the opening, with the microphone on. I wondered if I could ask you all to please be so kind as to turn your cameras on just for the opening so that I can smudge to the energy that you are. I would appreciate it, and then that way I can put that out to the person. And Yawagoa, I appreciate it. I'll give you a few seconds to do so as I light this smudge. And when I do, I just wanted to share with this kind group, this circle, this energy. There I can see there are 211 participants here at the bottom of this screen that I look at when I see participants. That means there's 211 energies sitting here wanting to talk about structural stigma, wanting to talk, wanting to share, feeling comfortable enough to be with each other You all carry these letters of legitimacy for what you do for work, but inside you is the child of a heart of a child. Inside you is a story. Inside you is the one that wasn't heard or seen at one point in time. And you built yourself around that. When I received this tobacco, it was in the mail, and it was the first time I'd ever received tobacco in the mail. I'd always received it from someone. They looked at me and they asked, "Would you help?" And I would say, "Of course. If I can, I will. If I can't, I'll find someone who can." But because you're trying to find that help, and that's what we all do, we need to find our help. I don't care what you do for work. You need help as much as anyone else does. We need to have that humility to say, "I could use some help. I am in need. It's my turn." When I received this, I felt heard. That this is a teaching where you give someone tobacco if you're going to ask them to do something for you. And this opening is what I agreed to do. But I received this as it's a protocol, yes, but it's got its own spirit. It's got its own energy. This inside this is tobacco, and tobacco is a communication medicine. And I'm going to have to share with you that the reason Indigenous people didn't experience themselves well in these systems is because we weren't communicated with well. No one took the time to communicate with us and learn from us, even though each of you arrived here at one point in time in your family's life. So when I received it, I felt communicated with in a kind, loving way. And that's what this is all about when we break down these barriers, is to be kind and loving and to be gentle and to fail away in front of one another in kindness. So when I received it, I just wanted to say that that's what this means to me. That's wrapped in red. It's a color of passion and energy. And I'm certain that each of us here carries a passion to change the world around us. And nothing changes if nothing changes. And we are creating change just by doing something as simple as this, getting together and talking about breaking down structural stigma. So when I light this smudge, I light it, we call this an opening, but it doesn't mean the beginning or a start of something. It means to open you up, to open your energy, to open your mind, to open your heart, to open your words, your eyes, your spirit eyes. I put it out there for the time you weren't heard. I put it out there for the time someone promised you they would show up and they did not. You trusted they would. It was very important to you that they did, and they did not show. I put that out there for what that means to you. I'm convinced that the reason we had to go through that was so that we could understand what it felt like to have such a void, that we would not fill it by the rest of our story. We would fill that void. And when someone else struggled, we would say, "I know what that feels like. I'll help you. I know what that feels like. You won't feel like that because I'm here." Whatever that means to you. Sometimes the most difficult apology you'll ever have to accept is the one you'll never get. So I hold this up here. I hold this up here for the time that you felt unheard, unseen. And now you stand for what that voice must mean. Because I have certainly witnessed kind people that I work with try to change the world around them so that people that struggle feel like they're seen and heard. So I put that out there for the Eastern direction. New beginnings. What you need is promised to you every day by the sun as it rises. That's what you're gifted every day. New energy to deal with what it is you're dealing with right now. I put it out there for your southern direction, which is this direction, the red, the good energy that says, "I'm passionate about this and I really want to make this change." I put it out there for your western direction, and that reflection about who you are and what's important to you, what you're grateful for. And the last direction I put it out there for is the northern direction, for clarity of thought, purity of mind. And I hope that this finds you in a good way. I send this to you in good kindness, and I look forward to our conversation today. Nyawa Goa for allowing this medicine in this conversation. Nyawa.
Thank you, Bill, for helping us to ground us for our gathering, helping us to open our hearts and minds, and helping hands. And may the true message of this webinar be shared and heard amongst us all. If we can show the slides again. So before diving into our webinar topic, I'd like to take a moment to thank our amazing team that has worked so hard behind the scenes to prepare us for today's conversation and for their support. Nicholas Waters, Samuel Bro, Uyen Ta, Carolina Chadwick, Sari Chunduri, our partners at America Interpretation, HealthCareCAN, and members of our Quality Mental Health Care Network. Our objectives for today's webinar include an overview of the mental health care framework, quality mental health care framework, which identifies 10 dimensions that define the quality of mental health care for service users, including providers. We will then focus on unpacking one of the framework's key dimensions, stigma-free and inclusive. And finally, we will share some resources to help you learn more about the framework and support you and your organization with regards to mental health and substance use related structural stigma. Next slide, please. We will begin with a brief presentation on the quality mental health care framework and structural stigma. Then we'll dive into a fireside chat with our panelists and regards to dismantling structural stigma, and we'll follow that by a Q&A. And next slide, please. So it's now my pleasure to introduce our guests for today's conversation. Joining us today, we have Bill Hill, who you've already met, Jody Younger, Vice President of Patient Care and Quality at St. Joseph's Healthcare London, and Samaria Nancy Cardinal, Patient Partner with Patients for Patient Safety Canada, and also a member of our Quality Mental Health Care Network, and Dr. Stephanie Knack, Senior Research Consultant at the MHCC. And final but not least, our fireside chat moderator and healthcare expert, Jonathan Mitchell, Vice President of Research and Policy for HealthCareCAN. And before I turn things over to Jonathan, I'll give a quick overview of the Mental Health Commission of Canada. We have a unique mandate. Oh, next slide, please. We have a unique mandate from Health Canada to lead and support the development and dissemination of innovative programs and tools to support the mental health and wellness of people in Canada. Please check out our website to learn more. And with that, happy to turn things over to you, Jonathan. And next slide, please.
Thanks very much, Cam. First, a few words about HealthCareCAN. HealthCareCAN is the national voice of healthcare organizations, including academic health sciences centers, regional authorities, hospitals, long-term care and home care organizations across Canada. Our membership includes more than 60 organizations across the country, including many national health organizations. At HealthCareCAN, we advocate on behalf of our members for enhanced research and innovation, as well as infrastructure. We advocate for policy solutions to bolster Canada's health workforce and provide policy direction to our members in many areas, including mental health and cybersecurity. Through our learning division, CHA Learning, we offer many courses on diverse topics such as leadership, patient safety, quality, long-term care administration, and food, service, and nutrition management. Our courses include a number of offerings in mental health, including a course on structural stigma developed with the Mental Health Commission of Canada, which we will come back to later in this webinar. Next slide, please. So it's been an absolute pleasure and delight to co-lead the Quality Mental Health Care Network on behalf of HealthCareCAN with the Mental Health Commission of Canada. HealthCareCAN and the Mental Health Commission of Canada co-lead the Quality Mental Health Care Network, which unites health leaders across the country to remove access barriers to high-quality mental health care services. The network's efforts address structural stigma, promote recovery-oriented practice, and improve access to quality mental health care. To help implement this vision, the network developed the Quality Mental Health Care Framework. Next slide, please. So this figure gives you an overview of the framework. The framework identifies 10 critical dimensions that define the quality of mental health care for service users, including providers. This new vision builds on the expertise of people with lived and living experience healthcare leaders and practitioners. Next slide, please. Let's watch a short video to learn more about this new framework.
Everyone should have access to quality mental health care, no matter where they live or what circumstances they're in. But where do people turn? Mental health affects everyone, including healthcare workers. But finding the right support when you need it, in a way that you can access it, is harder than it looks. For many people, seeking help means knocking on a lot of doors, at a time when their resources are already depleted. Finding no clear pathway, meeting one barrier after another, they often give up before getting the mental health care they need. The Quality Mental Health Care Framework works to support the entire healthcare system and improve the mental health of service users and providers. Through its collaborative approach, it can also improve how people access mental health care and increase their quality of care in the hospital and community through counseling, peer support, medications, and more. The framework offers a holistic approach to improving the quality of mental health care across the system. It provides clear, measurable dimensions that give service users the knowledge to identify quality care and the confidence to advocate for it when certain areas fall short. By adopting the framework, healthcare organizations are sending a clear message to people who need services, including providers, that mental health matters for us all. Everyone should be able to open the door to quality mental health care.
Okay, excellent. So I would just invite everyone today to learn, if you're interested in learning more about the framework's 10 dimensions, simply scan the QR code on this slide or access the link provided, and it'll take you to a whole host of resources with additional information on the framework. For today's conversation, we will dive into the stigma-free and inclusive dimension. I am pleased to turn to Stephanie, who will provide an overview of structural stigma. Stephanie?
Thanks, Jonathan. Hello, everybody. Next slide. Next. Oh, there we go. Okay, they're in French. So I will just spend a few minutes giving an overview on the concept of stigma and introducing specifically what we mean when we talk about structural stigma. So what is mental health and substance use stigma? So basically, most of the literature about the concept of stigma comes from sociology. And so sociological theory identifies stigma as actually a very complex social process that has several different components, including labeling, stereotyping, othering, and ultimately discriminating. And really, the way the literature talks about the processes of stigmatization is that it is all of these processes working together, the labeling, the othering, the stereotyping, that really allow the end step, which is discrimination, and really kind of justify discrimination towards people with mental health and substance use issues. The other important thing to know about stigmatization is that these processes are sustained through power relationships and social systems that actually reinforce and justify these processes in various ways. I think that's a really key point in framing our discussion today, because we are really talking about structural stigma. So we are talking about the social systems that are reinforcing and maintaining stigma in healthcare. The other thing about stigma is that it's often conceptualized as existing across four different levels, four main levels. The first one is the level of the individual. So we often think about this often as self-stigma, right? So this is kind of that individual internalization of those larger stereotypes and beliefs in the culture. And self-stigma, we know, can be very damaging. It results in shame, often reluctance to seek help, feelings of being less worthy. And we also have lots of evidence to show that self-stigma can really interfere with recovery processes as well. The next level of stigma that we refer to is interpersonal stigma, which is often also referred to as public stigma. So this is the stigmatization that occurs at the level of everyday interactions, right? So it's the negative attitudes and discriminatory behaviors and the language that we use that are enacted in day-to-day interaction. The next level, which is the level we're going to focus on today, is structural stigma. So this is when stigmatization is actually embedded into our rules, into our policies, into our processes, into our laws, and into our social norms as well. And the final level of stigma, which is a really important, it kind of encompasses all of the other levels of stigma, and that's the level of intersectional stigma. And this is when mental health and substance use related stigma overlaps and intersects with other types of stigma and other forms of discrimination or marginalization. So for example, discrimination and marginalization related to race and ethnicity, religion, sexual orientation, socioeconomic status, physical abilities, etc. Next slide, please. So just a little bit more on structural stigma itself. So this is a definition that is common in the sociological literature. Lincoln Fell and have been kind of pioneers in kind of understanding and conceptualizing what stigma in the mental health realm is. Another definition that I like that is very focused on healthcare, that kind of narrows it down into the healthcare space, is one that says structural stigma refers to the inequitable deprioritization, devaluation, and othering of mental health and substance use as compared to physical health. So we're actually anchoring it against something within healthcare delivery, governance, knowledge building, and training systems. And this structural stigma creates and perpetuates health and social inequalities and poor standards of care for people with mental health and substance use illnesses, and it ultimately also justifies them. Next slide, please. So in terms of some examples of how structural stigma results in inequitable care, here I just want to give a little bit of a credit to Dr. Jamie Livingston, who is a colleague of the Commission's and who has done a lot of really good research, several systematic reviews that have really kind of walked through how structural stigma actually shows up in the healthcare system and how it impacts people with mental health and substance use issues. And there's really two big buckets of inequity. One is issues related to access to care, and the other is issues related to quality of care. And just here a few examples, right? Problems of access include lack of available services, right? Chronic underfunding relative to the burden of disease in terms of the actual services provided, in terms of research, in terms of proper training, all of that kind of stuff. People who are looking for help often feel deprioritized, undertreated, or even denied access to care altogether, which is a very common story that we hear. The care that does exist, as we saw in that video that Jonathan showed, the care that does exist is often highly discoordinated and fragmented. It's very hard to navigate a little bit of the system that does exist. Examples in terms of quality, the big one, overarching one, is really negative attitudes and poor practices of people working within the system. That this has been identified as an actual issue of structural stigma, not just interpersonal stigma, because it seems to be often characterize the actual culture of care. And then another big one is overuse of coercive practices. coercive practices and punitive approaches to care. So those are just some examples of how structural stigma actually shows up in the healthcare system for people seeking support for mental health and substance use issues. And I will now, I'm going to take a sip of water and turn it back over to Jonathan. Thank you.
Okay, thanks very much, Stephanie. Appreciate that excellent overview. So we're going to begin our conversation now. So I'd ask our panelists to turn on their video as we begin the conversation. And so looking forward to this today. Let's start broad and help us better understand how structural stigma affects care. From the perspective that you bring to this discussion today, what comes to mind when you think of structural stigma? And Samaria, can I start with you to lead us off? I think you're on mute, Samaria. You know what? How about if we go to Bill and to Jody, and Samaria will come right back to you as we just work through that. Bill, over to you.
I'm muted too. Good old-fashioned technology. I feel that the systems were set up to only validate. I started back in 1982, so I watched the systems change over and over again. And they were set up to only validate Western treatment modalities. Even when people were coming from other countries with excellent knowledge and wellness, they still had to pass our standards of care, if you will, or be able to provide that kind of care, even though they were providing it in their own country. So these systems were set up to only validate Western treatment modalities from this Turtle Island or Canada or United States. And our knowledge was not included in our wellness as Indigenous people, if I'm going to speak specifically about Indigenous people. So when it's not included, trust wasn't present. And then building trust wasn't seen as a priority either by the organizations or the systems. There was no warm relationship that we could entice someone to come on in for treatment. And this, of course, would mean that we weren't coming in for treatment and our diagnosis would reach acuities that we had no choice but to come in. And when we were receiving care, we were at our worst, rather than being able to come in and know that we would be seen and heard, if you will. Even when we did come in for care, our indigeneity could negatively affect our provision of care and the level of care that was given to us. And when we go back and think of our Brian Sinclairs or our Joyce Saskatchewan, when we hear about this, these aren't 1950s, these are recent. So there was no concrete, effective communication surrounding Indigenous communities, like the way that we would discharge or do intake. There was no concrete communication that we could say that, did I not speak to a community agency, I should be speaking to a Bob or a Brenda or a Tom or a Carol, not that agency. We should have warm relationships. And that's the parts that I saw that didn't exist. And because they didn't, we weren't coming in for that care. Those are the things that I would see. And I'll leave it at that for now. Nyamagoa, thank you.
Okay, thanks very much, Bill. Jody?
Why don't we go back to Samaria? I think you're off mute now, Samaria.
Okay, perfect. Thanks, Samaria. Samaria, we're still having a little bit of trouble hearing you. Sorry about this.
All best systems tested, right?
Am I on now?
Now you're on.
Okay.
Fantastic, Samaria.
I just am having a lot of fun with technical today. Hello,
No worries.
everybody. I am honored to be here and to tell you a part of my story with structural stigma. It all began when I was pregnant and I gave birth to my daughter, and I ended up having a severe depression after that. And as a result, I was put into the Western colonial health system. And when that happened, they gave me a misdiagnosis that proceeded to pretty well take away 15 years of my life. I was put in a system that was Western, that did not understand my indigeneity, that did not understand my culture. I had a team with no Indigenous representation in it, and it created great harm to me. I was given medication, I was given shock treatment. As a result, I lost everything in my life, and I was not even able to parent my daughter. At the end of the 15 years, I did fire the team, and I received assistance that I needed from my community and started my way back to being healthy. And the sad thing about it is after that time, I experienced that. There was one time I went to the emergency department and I was experiencing health difficulties. My heart was pounding very fiercely. And when I walked into the emergency room, the doctor did not even check any vitals or anything. The first thing he saw on my chart was a mental health diagnosis and asked me if I was taking medication. And I thought that was absolutely horrible. And I ended up walking out of that emergency room when I should have received appropriate treatment. So what I do now is I tell everybody I can that we need to make changes. We need to be able to provide culturally appropriate care to everyone.
Thanks very much, Samaria, for sharing that very powerful experience. Jody.
Well, I think speaking to Samaria's experience and what Bill has spoken about as overarching themes, I was about, I think, 6 days on the job in this current role of VP at St. Joseph's Healthcare in London, an academic health teaching facility in London, Ontario. And I got a knock on the door from a Mr. Bill Hill. Introduced himself, and he said, hey, as the new leader who has accountability for mental health and 2 mental health facilities, 2 separate facilities, what are you doing about culturally safe care? And I think suffice it to say, my answer was, I have no idea. I have no idea, but let's talk about it. And that invitation to talk led to the development of a kind partnership with a number of partners, including an agency called Atlosa Family Healing Services, to submit through the Journey Together, Ontario's Commitment for Truth and Reconciliation funding opportunities, to develop a program now called Bigajisakan, Pathway to Mental Wellness. And the purpose of Bigajisakan is to start to untangle and break down those structural stigma, the kind of system issues that Samaria talked about, that Bill talked about, systematically, appreciating that it's a long road ahead of us and that we're going to have many hurdles, but the idea is to build out a program that starts to invite safe, culturally safe care. And we focused on our sort of pathway around inpatient healthcare. We moved that to our ambulatory healthcare, and the program has continued to grow past that. And just to say that it's not only about having physical space, which is necessary to have safe, inviting space where people can see culture and what's important to them, but it's also about systematically breaking down all of the different ways that we work with individuals who have needs, who are coming to us for help, so that it feels culturally safe to do so. So really happy that Bill knocked on my door. And I know part of the questions often is, how do you get started? And sometimes it's just with the first step. And for us, that was the first step. And I know we're going to get into some questions, again, to a bit more details of what does that look like. So I'll pass it back.
Hey, thanks so much, Jody. Stephanie.
Thank you. So what comes to my mind is, well, what's really fresh for me right now is a study that I'm currently involved in. At the in Alberta, working with a research team where we're investigating the issue of stigma in one specific setting, and it's an emergency department setting in Alberta. And the first phase of this research was just to get a handle on, how is stigma showing up in this environment? What does it look like? And what was really powerful that came out of this qualitative investigation was that all of the core issues were structural. There was absolutely interpersonal level stigma, like Samaria, speaking to your experience of people going in, looking for care and just being treated poorly, not being heard, not being acknowledged, or being, swooped in under the Mental Health Act or something when they didn't think that they, needed that level of care. So lots of kind of examples of mistreatment, if you will, or really not being listened to and heard. But what came out of all of our interviews was they could track that back to structural issues, that there were structural issues that were kind of informing that bedside, those interactions at the bedside. And I'll just give a few examples that came out. One was the staffing ratio. So the ED nursing staff, the ratio in the emergency room was 3-to-1 for physical health patients, but 6-to-1 for mental health patients. So, so every nurse had 6 staff, or had 6 patients to look after instead of 3 if they were looking after the mental health unit. What also came out very strongly is that ED nurses, ED doctors, protective services staff, they are the ones who are responsible for the day-to-day kind of bedside care of mental health and substance use patients, yet they aren't actually trained in mental health or substance use. So they are relying on psychiatry to come in as a consulting service. So the fact, though, that these nurses and protective services staff are the ones responsible for that kind of ongoing care while the patients are in there was identified as a real concern. Another thing, they talked about the state of the beds and the psychiatric beds in the emergency room. And actually every single person we interviewed, whether it was patient family member, staff member, protective services, talked about the state of those beds and referred to them as being like jail cells. Those were their words. And they also, several participants who were very familiar with that emergency department said that, they've seen renovations in that department over the years. Different things have been fixed up, dressed, but never those beds, that they have been like that literally for decades and decades. Although I do think that is finally changing now. And then another big structural issue they talked about was boarding, was this thing they called boarding. So basically this is referring to the fact that because there is a lack of inpatient beds in the rest of the system, people who are coming in with mental health emergencies are often stuck in the emergency room for several days, even a week or longer was not uncommon to hear, while they are waiting for a bed to be moved into. And our respondents said, this never happens with physical health to experience that kind of delay. And then in many instances, these patients are also being admitted under the Mental Health Act. So they are there in the emergency room for days on end, week or longer, under the Mental Health Act. So with very, very limited rights and kind of restrictions on their mobility. So yeah, that structural stigma in my mind.
Thanks very much, Stephanie, and my thanks to all our panelists for sharing these very rich perspectives. Lots to unpack as we move to our next question for the panel. And we've covered some of this already, but would ask you each for your perspectives on what are some of the structural barriers or challenges you have encountered in either accessing or delivering quality mental health care. Samaria, can we start with you?
Sure. For myself, when I was in the mental health system, I noticed that you have to be very, very sick to get the help you need. There is long lineups and waits for everything. And as a result, you can't get counseling that you require. So many times you are given pills to deal with your problems. And with myself, they just kept giving me more and more and more pills instead of receiving counseling, which I actually needed for trauma. And I never got what I needed. the whole time I was in that system. And the staff, they're not trained appropriately in cultural humility. Many of them come in, they've had a weekend course on Indigenous traditions, etc., and they almost walk in like they feel like they know everything. And that is absolutely impossible. When you come in, you need to be client-centered and to look at that client as the expert. They know themselves, they know their culture. Be humble when you walk in. Ask them, work with them. You are a trained professional, yes, but you're not an expert in everything, and you're not an expert on that client's life.
Thanks very much, Samaria. And just again, my thanks to you for sharing your story. We're seeing a number of comments in the chat about that. And we're very interested. In a moment, we'll move to some of your thoughts on solutions and how to really implement that into care. But before we do that, Jody, be very interested in your perspective, and then we'll move to Bill and to Stephanie.
Yeah, so Samaria, it's just a perfect example of exactly the purpose and intent behind the Big HealthCareCAN program, which was not just about improving people's cultural awareness and safety and all of that, which is a piece of it, but actually building a two-eyed seeing approach to delivering mental health services. And so that meant everything, as I said, physical space is required, but insufficient. That's not enough to just have a safe space for ceremony where people can see their community, but also truly building a care delivery model where Western medicine and traditional healing work side by side, hand in hand, to serve individuals in a way that meets their needs and that is culturally safe and informed. And the best way, I mean, there's many ways we can learn to address stigma and to learn to be better, but the best way to do it is working side by side and being open-minded and kind-hearted. And we had many different challenges that we came up against in doing this kind of work. And we always, we brought everything to circle. We resolved things. We had some difficult conversations. But I want to just give one really specific example that health providers, I think, who are listening in today would resonate with, that helped for me. It was like one of those moments where that light bulb went on around structure and how structure can perpetuate stigma. So a really concrete example is, so we have the shared care two-eyed seeing approach. So a client could have care from either or and both traditional healing, knowledge keepers, ceremony, and Western medicine. But Western medicine has a chart that they chart on, digital chart, paper chart, but there's a place where the physician writes their notes, the nurse writes their notes. And so as we built out this model, we said, well, where do the notes go on ceremony? How do you talk about that in a chart? But it's important that we're communicating and sharing with each other in order to learn, and in order for the person coming on shift at 7 p.m. at night to know what happened in addressing maybe some intergenerational trauma for a client who was being served there, and to understand that. So how do you share that? And at first, the charting people said, well, we could just make it a consult note, back of the chart, where you'd get your, dermatology consult note or something like that. And we're like, okay, sure, let's make it the back. And I'm going to say our team, Bill and the team, said, no. Hang on a minute. If this is side by side, the notes have to live side by side, because the person is a whole person and their story is in that chart. And that's important in the health system. And so we fought the right fight to actually change the structure of the charting so that the charting could be side by side, and that the ATLOSA providers who are working in our program side by side could be part of telling that care narrative for that client. So that's just a really concrete example, I think, of the structures that can inhibit us from doing the right thing, and how you have to sort of tackle them one piece at a time.
Thanks so much, Jody. And just to reiterate some of the comments in the chat, that's really an amazing, as you said, simple, but amazing addition for this. So very interested to hear Bill's perspective on this as well. Bill, I think you're on mute.
On purpose, so that because I live by a train here, so sorry. Anyhow, there's a bit of a history that goes along with Big HealthCAN too, and my family's origin at the hospital. when it was London Psychiatric Hospital, or even before then, when it was the Ontario Hospital. My father was a nurse, and he was Mohawk. And he didn't know any of his teachings. He was big, he was brown, beautiful, kind soul, but he didn't know who he was. And his father was in the war and was harmed in the war. And in order to get his pension, of course, he had to be Canadian, and he forfeited his status. And our family lost his status, is the story that I've been told. We got our status back, but my dad and his dad didn't have a good relationship. And when that happened, my father was troubled by it because he was the eldest son. So there was generational trauma that was sitting there in my family that at one point in time I had no idea about, because I too hadn't picked up a feather. I too didn't know who I was. And when I did, that feather turned into a key, and the key was to a treasure. The treasure was the teachings and the culture and the identity that my father and I and my brothers and sisters and my children missed. There's a sense of identity, a sense of belonging, a sense of safety, all the things that are required for mental wellness. And when I realized that, I went to ceremony for the first time in my life. I was raised Anglican. When I went to ceremony, my life changed. I realized there was a sense of belonging that I never experienced yet. But I wanted that from my father so bad, because he was such a sweet man, but he didn't know who he was. And when I finally got my father to go into ceremony, he was a nurse at the hospital. When he finally got him to go into ceremony, I watched him turn into a child. I watched him turn into this new person, very beautiful, very demonstrative man, but he became himself in a different way. He cried for the first time about his dad's leaving, but he cried out of one eye with sorrow and the other eye with healing, because he finally understood the troubles that my grandpa must have gone through, because he was from residential school, but he never knew about residential school. My dad was raised in London. Generally, father will watch his son walk for the first time and talk for the first time. I watched my father do that for the first time, and it was an honor to do so. So when that put the fire in my belly for HealthCareCAN. So I'm taking it back to that. But you have to have, everything has a spark. That's the spark. When the beauty of your hero has another wing again, just gets another dimension to him. So what I noticed at the hospital was that there was this absence of cultural inclusion and care, and that was the barrier. And there wasn't anyone from the Indigenous community guiding treatment. It wasn't seen as valid to provide culturally inclusive care due to just societal norms and expectations of what care was. And we need to have someone from the Indigenous community to assure that Indigenous guided care would be implemented in that mental health care being received from people at a Catholic psychiatric hospital. We needed that two-eyed approach, like Jody was saying. We just needed it. We used culture as care and identity as treatment. Was being utilized as a means to create a sense of safety for Indigenous patients in the healthcare system. And once we implemented that culture as care and identity as treatment, the efficacy became so apparent that we were able to obtain a significant budget to do a permanent program supplied by the government of Ontario, the funding, because it was so evident, the efficacy. So that's what I've seen that. So I'll leave it at that. And thank you for letting me share some of my family's story.
Thank you so much, Bill, for sharing that. Extremely powerful, and really, really appreciate you sharing. And I think we'll move in just a second to the next question, which is more about change. But just before that, Stephanie, over to you for your perspective.
Thank you. Thank you. So I guess I'll speak again about some of the things I see as a researcher who is often working with different teams and organizations who are implementing different kinds of stigma reduction initiatives. And I'll perhaps use an example of stigma reduction via education and training. because that's a very common approach and can be a very successful approach as well. And so, for example, trauma-informed practice has shown considerable promise at actually affecting structural change and reducing structural stigma, if that can be successfully embedded and sustained within a culture of care. And we've also seen that it can be a really great entryway into providing more culturally safe, right, environments of care, and it opens up that doorway. But the challenge that I often see is exactly with that sustainability piece, especially when you're entering it through a lens of education and training, is I think we see, and I think it's because cultural change is disruptive, right? It is disruption. It is about a different way of looking at things. It's a different way of thinking about things, just as Bill said. So there is naturally bound to be resistance. It requires a lot of perseverance. It requires a lot of dedication. It requires commitment from the team and a willingness to feel uncomfortable, I guess, and to not know things, and to and to be vulnerable. And that is very, very difficult, I think, to do in healthcare, especially. So I guess when I think about, say, trauma-informed practice or other kinds of educational type models that can be used as vehicles for structural change, I see a lot of really, really great effort put into content, to building really great training content, training programs. And I see a lot of really great attention to rollout. Kind of how do we, kind of get this into the hands of the people who need it. But where I think we often fall short is in terms of building implementation models and thinking about implementation and measurement, where we want to get to, that actually looks out 6 months, a year, 2 years, 5 years, so that we can actually sustain and keep alive the thing that we're wanting to shift and grow.
Thanks.
Yeah.
Thanks so much, Stephanie. Appreciate that. We're going to try and squeak in 2 more questions to our panel before we move to questions from all of you, which we very much look forward to. So next question to the panel, as I said, we're going to change gears somewhat. The question: how can an organization prioritize the meaningful participation of people with lived and living experience of mental health and substance use illnesses in the design, delivery, and governance of healthcare? So we'll maybe switch up the order a little bit, but Samaria, can I start with you again on this one?
Sure, thank you. I think it's really important is there seems to be in our healthcare system this, it's like a hierarchy. The doctors are on top. There's the doctors, there's psychologists, and it goes down, and the actual service user is at the bottom. And people that work in the professions feel that because they have been to university and because they have training, they are the experts and they know. Well, unfortunately, they don't. They know, yes, they've been to school, and yes, they have knowledge, but they need to start walking, as other panelists have said, side by side and get some humility. They are not the experts. They do not know everything. And the sad thing is, many of them can have cultural training. They can receive cultural awareness, but they still walk with their biases. And they come out and they harm patients. So there is a huge issue there. It's still happening. I am in graduate school right now, training to be a therapist. And let me tell you, there is not enough of it in school, cultural humility and cultural awareness. And I am learning side by side by some individuals, and I feel they have no right working with Indigenous people. So I am experiencing it every day. And I'm with a cohort that's going to be graduating at the end of July in 24. And that is extremely sad. It saddens me. It really saddens me. And I don't know what they're going to have to do to change this, to create an environment where it's safe for service users and where professionals can learn that they need to change their attitudes and their biases.
Thanks, Maria. Bill, what would you add?
To Samaria's point, there's not any of our indigenous languages that has the word expert in it. I don't know of any word for expert in any of the languages that I have had the opportunity to even talk to elders or whatnot in. I have always asked them, what is that? Is there such a thing? Because I want to make certain that when I'm speaking, that I don't know of the word expert or anything like that. So I just wanted to make certain that I did share that part of it language-wise, because our language is our culture. Our culture is our way of knowing, and we don't know ourselves as experts. The only thing I'm an expert on is me, and I'm struggling with that. So anyhow, one of the things that what we did with the hospital program was that we insisted that those we served had a voice. We insisted that those we served had a voice in what we designed. As we were designing it, we made certain that we had people who, after receiving treatment with indigenous modalities in tandem with the Western medicine, they would assist us holding programs for their peers, utilizing ceremonial knowledge and traditional skills like drum making and beading, and those simple things like beading taught our kids patience and artistic expression in tandem. So all these things that we do, we always try to do things in tandem so that there's a tactility to our knowledge. There's something we can do as well as know. And even the drum making, something as simple as making a drum reanimates tissues of the deer, of the tree, of the self, of the spirit, and changes those things. So imagine being able to say that that's what we want to include, encourage other people to engage their cultures and receiving care at the hospital, that they might just want to try a psychotropic medication or perhaps a cognitive behavioral therapy session because they were seen and heard. Those were the things that changed too. I watched people want to engage in Western medicine because their identity as treatment was involved, their culture as care was involved. Then they started to trust differently because they were seen. So,
Thank you very much, Bill. Jody, Stephanie, what would you add to this?
I think I'd just say, just do it. There's nothing that gets in the way of engaging people who receive care from you and helping build the care that they're receiving. And listen with an open heart and an open mind, and appreciate that everything you're going to hear isn't going to be great and nice, and that's important. And that actually, if you're hearing the things that aren't great and nice, it means people are feeling psychologically safe to share those things, which is the first step. And I'll just leave it with saying that one thing, as I was in my early journey in this one, and you hit a point as a settler where you have just this shame and guilt and like, how could I not know? And you can get stuck in that, right? And it can also scare you from change. And one thing Bill would always say to me, and he would invite others, is to say, you know what, we didn't create the past. The past is the past, and it's here, and it's what we're living with. It's a legacy of today. But what are we doing to change tomorrow? So that kind of unlocks you from the shame and guilt to actually enable and enliven you. And so just ask people, sit down, talk to them, ask for their input, sit in circle, participate. Really, that is just the simple first step. And then it grows. It grows because when people see that their voices matter, they want to engage further, and you can grow that patient and people lived experience voice.
Okay, amazing. Thanks, Jody. Stephanie?
Thank you. Yeah, Jody, just amazing. And I think what I think about is I go back to our Champions and Changemakers project, which I was involved with a number of years ago with the commission. And Jody and Bill were very central to that project, where we learned so much from them. And one of the key things that we learned from all of the initiatives that we learned from through that project was that meaningful involvement of people with lived and living experience is essential for structural change. It absolutely is. And we also learned, though, that there isn't, I think to Jody's point, there isn't just one way to do it. It isn't just one model for everybody. There's lots of different ways to have this meaningful involvement. But I think some of the themes that came out of this Champions and Changemakers research was we learned that there are kind of some key characteristics that that kind of make this involvement work. And one is that all of the initiatives that we learned from, the relationship was formalized in some way. It was embedded and formalized in some way. So I think that was really important. The other thing is that all the initiatives were really cognizant of the potential for tokenism and the harm that that can cause. And they were really committed to true engagement, meaningful involvement. So I think because of that, they had to be willing to create that safe space and to also start to rebalance power dynamics, to become aware of power dynamics and be willing to let go and renegotiate some of those. And then the third big piece, which is, again, very, very central, is remuneration models that in all of the initiatives we learned from, the payment structures and the payment models really did reflect the value of the expertise that was being provided by people with lived and living experience. And I think the other thing is that the structure of the payment also matched what their needs and preferences were. And that was not always easy to do also, right? Sometimes that in and of itself required structural change to create a compensation model that actually worked. But I think those were three big themes. Yeah.
Okay, great. Thanks very much, Stephanie. We're going to move to our last question to the panel before we move to the Q&A. And I'll just ask our panelists to keep their answers short to 1 minute each. That will be a challenge because this is a very interesting topic, and we'll pick up some of your additional thoughts in the Q&A. So the question is, how can an organization get started in dismantling structural stigma? What is one piece of advice or one recommendation you would give participants today as they start or they continue to address the stigma-free and inclusive dimension of the quality mental health care framework? Stephanie, can I start with you this time?
Sure. Well, I'm just recognizing my bias as a researcher and coming from a research background. I'm a measurement person. So I really do, I would say, first of all, recognize it's a long game, right? Recognize that no matter what your position is in the system, you always have some kind of sphere of influence, right? You can always do something from where you are, but recognize it is a long game and it's going to take time and patience. But just try not to get frustrated. But in terms of the actual kind of hard stuff, I would say pick an indicator, start to measure something, some kind of thing that makes sense for your context, where you can that can be kind of used as a baseline, and that you can use it over time to track success and change. Yeah, it doesn't count until you start to count it. That's the old adage.
Thanks very much, Stephanie. Jody, what would you add?
Phrase I would use is relentless incrementalism. You know what? Sometimes you just got to start and you got to keep walking and just slowly make the change, because it can get overwhelming when you look at the magnitude of change there is. So just keep at it and pursue it, even in the tough times.
Okay, thanks. Thanks so much, Jody. Bill, how about yourself?
Well, I would say just be patient and be tenacious. Look for accomplices, not allies. Allies, they support what you do. Accomplices, they do what you do. So I look for those accomplices with experience in creating change, and I knock on the doors of the decision makers. I knock on the kind doors like yours, Jody, and I knock on the doors like Dr. Arlene McDougall, who co-created this whole piece along with Vicky Smythe. And the four of us really sat down and said, you know, we need to create a relationship with a partner that fosters kindness as its root. The safety, where you can fail in front of each other, is viewed as empowering. And it means that when someone says, I don't know, that it seems like it's positive. Because there's always something to learn together as you transition into a new path. We've all worked with a know-it-all. The unfortunate part is that's all they know. They won't learn anything else. That's been my favorite part of this journey. It took 25 years to start this up. And now I know it's going to last for eons. But that's what tenacity does. And that's what kindness does when you put them together. And it's not, I've said this to Jody in the hospital before, it's not my tenacity that made HealthCareCAN or programs like it successful. It's the kindness and the openness of the organization that you're trying to do it in that wants to learn and do better. That has to happen. And it has to happen under the guidance of Indigenous people if it's Indigenous care. And that has happened. Wholeheartedly, or I would not say it. But yeah, for that, that's how I would answer that.
Thanks so much, Bill. Samaria, what would you add?
I have been trying to create change for a number of years now, and I have patience, and I also have hope. And one thing that I received as a teaching is everything I do, I don't just look at today. I don't just look at tomorrow. I look 7 generations ahead. And I always think how it's going to affect my daughter, my grandchild, and all those people that are born after me. And when you think like that, then you see the broader picture and how the little raindrop that falls down today can become an ocean. And you always need to remember that.
Thank you. So really, I'd like to take this opportunity to thank our panelists so very much, Samaria, Bill, Jody, and Stephanie, for their very rich perspectives and the solutions that they've brought and shared really in this webinar. So appreciated. We're going to move to our Q&A now. There are a number of questions in the Q&A. We'll try and get to as many as we have in the time remaining. But I'd also invite our audience members to pose any additional questions by typing them into the Q&A box. So just to start, first question, interested in some thoughts about how structural stigma affects high rejection rates of referrals. Who would like to make a comment on that? Jody?
I could start, at least from the system perspective. You know, one of the things we've learned in untangling, and we're still working on this, is how do you create a system that invites and encourages people reaching in for care versus tries to sort out all the people who shouldn't be coming for care. And a lot of times those intakes, pathways, they're actually asking you questions to sort of systematically reduce the number of people coming through the door, kind of to the video, the point of the video. And I think one of the metaphors in the video was, you know, that no wrong door thinking. And I think that's what systems need to start to do. They need to consider, how are we asking questions and how are we taking into consideration cultural safety? And I noticed in the chat folks talking about other cultural barriers outside of indigeneity. And it's true, these same principles apply. How do we actually open the way we ask questions and invite people to service to help them get to the right place versus discouraging them from coming to our door, which is kind of how it feels right now, which often lands people in front of no door. So I loved the video because to me, that's my mental map of the problems in our system right now.
Thanks very much, Jody. Let me introduce another question into this, and we'll then go to someone else, and if they wanted to add to that as well. An interesting question here about how the lessons that we've shared today can be applied to the experiences of someone before they enter the healthcare system. They're asking about supports in the workplace, in workplace culture, early education of individuals, families, and communities to aid in dismantling structure. Who would like to begin with that?
I can speak a little bit to that.
Thanks, Stephanie.
Yeah, and I guess a lot of the things that that we've been talking about today absolutely do apply to other contexts and environments, workplaces, schools, other different kinds of community settings. And I'm going to, what comes to mind actually is some research that I've done, again, in conjunction with the Mental Health Commission of Canada around their the Working Mind program that is offered in many workplaces across the country. And again, in some qualitative research that we've done, where we've tried to understand implementation and culture change as a result of bringing in that program, you do start to see again some shifts in the culture, some more willingness to seek help. You see that again, a training like this can come in and create space and open the door where people go, okay, actually our workplace isn't very psychologically health and safe. We need to now implement, you know, other structures. And so it can be a door into additional structural change. So yeah, again, just that finding the partners and having that consistency and that commitment and starting to make incremental change bit by bit through different
Okay. Okay. Thanks very much for that, Stephanie. I'm going to hand it back over to Cam, who's going to close. But we'll make arrangements as well for if there are any additional questions, how to get those to the panelists and get responses to that. And again, a huge thank you to all of you for this very rich discussion today. Cam, over to you.
Thank you, Jonathan. If you can just go to the last slide, please. Thank you. So yeah, we encourage you to visit our website to learn more about the Quality Mental Health Care Framework. You can see from today's wonderful conversation with our panelists and Jonathan that while we were talking about structural stigma and inclusive dimension of the framework, the panelists also touched on so many other dimensions: trauma-informed, safe, appropriate, people-centered care. So I encourage you to use the QR code, go to our webpage to learn more about the framework, and we'll also put the website link in the chat. We also have some resources as well, additional resources in partnership with CHA Learning. The MHCC is pleased to offer an e-learning course. It's entitled Mental Health Structural Stigma in Healthcare. And this training is an accredited and free self-paced online course. It takes about 1 to 1.5 hours. And it's highly interactive with concrete examples, case studies, videos, reflection questions. So I'll encourage you to use the QR code, and also we'll have a link in the chat to access that. And also finally, we have MHCC has developed an implementation guide. It's entitled Dismantling Structural Stigma in Healthcare. This guide is to share knowledge about the key features of structural stigma and to provide guidance for those interested in reducing stigma in their organizations. And it draws on real world insights from organizations. So lots of strategies, tools there in the guide. And we'd like you to keep an eye out on our MHCC website to learn more, or visit our website to learn more about structural stigma, and watch for updates. And we'll get closer to the big reveal of this implementation guide to be able to share it with all of you. So we'll have a recording of this conversation on the MHCC website in early 2024. And before our closing ceremony, I would like to take a moment to thank all of you for joining us on our webinar, and a special thanks to our guests for your insights, for your perspectives. And I'm going to pass it back to Bill, who is going to close the session in a good way. Thank you, Bill.
No, we'll go. So I'm going to do something as simple as if I could just, are we able to see all the other participants' cameras too, or just ours?
Their cameras are deactivated.
Very good. So everything started with this spark. Everything that we're talking about today started with something as simple as the spark. And when we do that, that is the beginning of everything. That is the beginning of the change. And that goes for what you need in your own personal life too, not just when you're trying to create change in the healthcare system. Because the healthcare system starts within. The healthcare system starts in here. Make sure this is in order so that you can put that in order. That goes for your family. That goes for the ones you love that are right next door, the ones that are in your community, in your nation, whatever that means to you. You cannot do the work until you do this. Be selfish when I like these smudges. Love who you love. Make sure you're friends with you. Make sure you take care of you first. You cannot care for others without your wellness. It's okay to be selfish. It's okay. Put you first. It's okay to be kind to yourself. You should be as nice to you as you are to all those other people that you're being nice to. And I know that you're not from time to time because you're like me. You're breathing. You do not have to be perfect to be beautiful. Put that energy out to those people that you love, that you know struggle from time to time, that you hold dearly, and you wish you could just touch their forehead and tell them how much you love them. And they go, oh my gosh, really? You go, yeah, really. Do that for yourself. I hope you love you. I truly do. I know you struggle with it from time to time, and so do I. We've all had the moment where it's like, what's going on here? How could it be? And then here you are. Here you are in this moment instead. I hope this moment finds you well. I hope the smoke finds you unwell. And then it finds you, because sometimes we feel so lost when we're unwell. So I put that out there for what that means to you, because it's okay to be not all right. Much love to you. Be very careful. You're a very gentle being. You're a very vulnerable being. Be kind to yourself. Take care. Thank you again for this opportunity. Yeah.